thanks everybody for joining us this evening. As I mentioned, we are talking tonight about what providers need to know about normal and pathologic ovarian aging. Just a quick note about Vios Fertility, in case you're not familiar. We're really guided by our core values, that of vision, innovation, teamwork, and passion. And one of the ways we express these core values is through education, both for our patient population as well as for our partners in the provider market. It's something that we're very passionate about, we feel is helpful to everyone, and we certainly appreciate the conversations that the education results in. So thank you everybody for being here tonight and for the discussion that we know is going to come as a result. I want to introduce you to our panel, to our amazing speakers this evening, all Vios physicians. And we have Dr. Amber Cooper from our St. Louis region. She's actually one of our co-directors for our Center of Excellence on Ovarian Aging. And then we also have Dr. Roohi Jeelani from our Chicago region. She is the other co-director of our Center of Excellence on Ovarian Aging. We also have speaking with us today is Dr. Ellen Hayes from our Milwaukee region and Dr. Julie Rhee from our St. Louis region. So I know you'll learn a lot. We're delighted to have all of them on our team and can't wait for what they have to share with you. So with that, I'm going to turn things over to Dr. Cooper to walk us through what our Center of Excellence is all about and then take things from here. So Dr. Cooper, over to you.
Thank you, Erin, and good to see everybody virtually. I'm hoping that COVID is a thing of the past in 2021, if we can only be so lucky. So as Erin said, you know, one of all, I should say, near and dear to the heart of all of us providers is creating the Center of Excellence and really strive to have patient-centric care. And so, you know, our Center of Excellence that's very specific to ovarian aging really is trying to provide a personalized, individualized approach to ovarian aging, which includes patient, provider, and community awareness, which is one of the things we're trying to do now, education for both the community and our patients, and diagnostic and treatment strategies that still follow our Vios mission, where they are cutting edge and very patient-centric. It provides both short and long-term treatment strategies, as well as access to research studies, which we have many, many coming down the pipeline, and cutting-edge technologies. Next slide. So really big picture for just a minute, what is ovarian aging? So ovarian aging is loss of both quality and quantity of follicles, and we'll touch on both tonight. And, you know, it's really influenced by genetics, the environment, and your initial endowment of your egg pool, as well as loss over time. Next slide. So when we kind of started with this, can be, you know, what's normal and abnormal ovarian aging. And we really hope in these slides we can hit on both of those things. The important thing, and I tell women this every time they come to see me, we have a finite pool. Women don't make eggs like men make sperm. You know, when you are a 20-week fetus in utero, you have maybe about somewhere between 3 to 5 million eggs. There's a lot of sort of mixed numbers out there. You lose about 80% by birth when you're down to about 1 million or less. And by puberty, you're probably down to 500,000 or less. So it's kind of crazy that we lose 90% before we care about them, but it's a slow rate of loss over time. I always say we have this jar of jelly beans and we lose a handful every month. And that picture in the upper right corner, I always try to kind of put in a plug when you're doing surgery, that even small amounts of ovarian cortex that you leave behind quite a few eggs. So sometimes when you think you have to take that whole ovary out, it's worth kind of keeping small amounts in. Dr. Jeelani, you're up.
So what is ovarian aging and what does it truly mean? Ovarian aging can be normal or pathological. And typically when we assess ovarian aging, what should we be looking for as providers? There's a couple things that we typically suggest. One of them is kind of like the new sexy marker fertility. I'm sure you all have patients coming in and asking for it. That's your AMH, your anti-Müllerian hormone. And it typically goes hand in hand with your AFC, which is your antral follicle count. And those are pretty powerful predictors of your current ovarian reserve. We oftentimes, when we introduce this concept to our patients, tell them it's like their bank account, their 401k, of what's left in their ovarian pool. This may be impacted by factors such as genetics, environmental factors, which may cause accelerated loss of your ovarian pool, leading to ovarian aging or premature ovarian insufficiency. So we're trying to understand each individual's ovarian reserve and how do we preserve their fertility and kind of move away from that term social egg freezing. It's not necessarily social, it's more of a medical or fertility preservation indication. So how do you evaluate these patients? Typically, these patients may present to you with a family history of premature menopause, so early recognition of what their family pattern looks like. They may present with shortening menstrual cycles or more pre-cycle spotting, saying that I've ovulated, but I started spotting 4 days before my period. They may have a strong medical or surgical history with extensive factors such as endometriosis, lysis of adhesions, or cystectomies. They may present with doing something called like your AMH or your FSH, which is worrisome, which does not necessarily fit in those normal parameters for their age. And we'll deep dive into what that means for your age. They may have an ultrasound showing a lower antral follicle count or a smaller ovarian volume. And then we can further do genetic testing to see if there's any genetic link causing this, such as Fragile X. So typically, these patients may present with initially being fertile and come to you with, well, you know, I had my first child successfully, and now I'm going through recurrent pregnancy loss. But why? Typically, Dr. Rhee will deep dive into this, but RPL, meaning recurrent pregnancy loss, can go hand in hand with lower egg quality, thus increasing potentially aneuploidy, meaning chromosomal abnormality, which initially they'll present as recurrent pregnancy loss, then lower reserve, and then insufficiency in early menopause. So how will they present in terms of their cycle? Initially, they'll present with normal cycles, and they'll come to you with saying, well, you know, I've noticed my ovulation's getting earlier and earlier, and my cycle duration is shortening. Then they'll come with anovulation, meaning I was ovulating and I lost track of my ovulation. And then eventually, when they become perimenopausal, have absent to no cycles. So how do we put that into where it falls under natural menopause? It's a wide variation depending on your family background, how many you were initially born with, your variation, and how your ovarian acceleration happened and decay happened throughout. So genomics has a huge role to play with it, right? Whenever we're doing our intake, we always ask our patients, when was your mom's age at menopause? Do you have a family history of recurrent pregnancy loss? And oftentimes it becomes really difficult, which Dr. Rhee will also touch on, because the age of first child is much different 10 years ago or 20 years ago when our parents were having children versus now. So there's been studies that have shown, mother-daughter studies, where there is an age of menopause located on the X chromosome, and a lot of these are often associated with DNA repair genes which can potentially be impacted by environmental, oxidative stress, DNA damage, and potentially worsen in subsequent generations. For example, so if you look at the X chromosome, small deletions in the long arm or the short arm of the X chromosomes can potentially lead to premature menopause, secondary infertility, or amenorrhea. So what are the models of ovarian aging, and what can we use, what tools can we use to assess? And we'll touch on different studies. So we want to develop an accurate model. We want to be able to tell these patients what their reproductive potential is and what their age of menopause may be. Currently, AMH is the best tool to predict ovarian response. We always need to counsel our patients. It is not by natural conception. So patients often ask, well, my AMH is low. Does that mean I can't conceive naturally? It does not mean that. This is just to help us as doctors predict how many eggs we may get when we're going through egg freezing or IVF. Initially, we thought there was a linear decline, that as time progressed and as age progressed, that you'll see a slow decline, but no one ever knew the delta of that AMH. Now we notice that there's multiple factors that influence AMH, and it can be stagnant, it can go up, and it can vary. So let's look at what that magic number is. Initially, we thought when should we tell these patients, because we know there's a slight variation and we know that the AMH doesn't steadily decline. What is the age, the magic number to freeze your eggs? Initially, when you look at the cost benefit analysis, they came back and they said 37. The study that said that, they said, well, if you freeze your eggs at age 37, that means you don't have a suitable candidate or are looking to conceive in the next 2 years. By the time you come around to conceiving, you'll be closer to that 40 mark. So it's cost effective to freeze your eggs at 37. However, when you look at the model, the decay model of your ovarian pool, you notice that there's certain limitations, and it doesn't necessarily happen in our mid to early 30s. So this is done from an autopsy studies when you look to say, well, how is your ovarian pool and how does it start decaying? And if you notice, even at birth and continue throughout, your ovarian pool, total number of follicles and eggs, is declining. So they notice, well, this is the best model currently for FIT. So there's really no sudden change and no magic age, and it's a smooth change over time. So the conclusion said that the time to menopause in ovarian pool is a steady decline. So when we always come back to this, we say when your patients ask, when should you freeze your eggs? It's always younger the better.
And
right. Dr. Rhee.
Thanks, Roohi, for that information. So thanks again, everyone, for joining us tonight. So excited to talk to you guys about ovarian aging, which is obviously a topic that is near and dear to all of our hearts as REIs. So just to kind of as a segue from what Roohi was just talking about, you know, that those studies were really interesting and, you know, very sort of complicated if you look at all those graphs, but if you break it down, you know, what does this data actually non-log transformed actually mean? So if you look at the graph on the left, that's the percentage of follicles that are remaining. So the x-axis there is age, or how old a woman is. So as you see, and we all know this, is that as a woman ages, that the number of follicles remaining really will exponentially decrease. What's interesting is if you look at that graph on the right side, that breaks down the average follicles that are lost. And if you look at that peak there, it actually comes at about age 20. So kind of what Amber, like Amber was saying at the beginning with that well-known spear-off graph, it is a gradual sort of depletion over time. And although we tell patients a lot of times, we talk about age 35 being of advanced maternal age, and at age 37, if you look at the SART database, which is the database that, you know, most clinics will report their IVF success rates to, although 35 and 37 get a lot of attention, what's interesting is at the peak, it's about when a woman's in her 20s. So, so next slide. So we're going to shift gears here for a second and talk about recurrent pregnancy loss and ovarian aging. I think this concept is very interesting and something that is starting to gain more steam, and you know, there's definitely more emerging data on it. But you know, in general, when providers evaluate recurrent pregnancy loss patients, so patients who've had 2 to 3 clinical losses, typically we don't think about, or providers don't often think about checking an AMH or looking at an antral follicle count to evaluate ovarian reserve. But what we are seeing based on some recent studies is that there is a link between recurrent pregnancy loss and diminished ovarian reserve. The exact etiology and the biological plausibility is something that's continuously being studied. However, some proposed theories include whether maybe this is due to increased aneuploidy, as Amber and Roohi both touched upon. Perhaps women, as they have this decline in their egg pool, also have a decline in their oocyte quality, leading to recurrent pregnancy loss. Also, proposed theories include hormone dysfunction from shortening cycles. As we know, women with diminished ovarian reserve start recruiting follicles earlier on in their cycles, so in the luteal phase, which is not typical of someone with normal ovarian reserve, and therefore potentially some hormone dysfunction that can lead to shortening of cycles, and then the recurrent pregnancy loss, which also goes hand in hand with luteal phase deficiency, which a lot of us have heard of. And then increased inflammation associated with hormone dysfunction. So, you know, potentially, so we've heard that there have also been studies looking at in women with recurrent pregnancy loss, if you supplement with progesterone in the luteal phase, potentially that will help because progesterone being an immune modulator. So women with recurrent pregnancy loss and diminished ovarian reserve also having this increased inflammation that kind of goes hand in hand. Next slide. So the first study that's here, it was published in Fertility and Sterility in 2020. It was a systematic review and meta-analysis that looked at that women with recurrent pregnancy loss. And what they found was they had diminished ovarian reserve, more diminished ovarian reserve compared with women who did not have recurrent pregnancy loss as measured by AMH and antral follicle count. So antral follicle count is the follicle count that we look at the beginning of a menstrual cycle, typically on cycle day 2 to 3, that gives us an idea of what the egg pool looks like that cycle. So, so it's really interesting just to kind of see that there seemed to be a correlation between recurrent pregnancy loss and diminished ovarian reserve when you look at those markers. Next slide. Another study that I'd like to highlight here, also in Fertility Sterility in 2018, this was a prospective cohort study that looked at 533 women, age 30 to 44. Important to note that these women had no history of infertility, no PCOS or endometriosis who conceived naturally. And it's important that those women were not included because those are obviously confounders. Women with PCOS, there have been theories about potentially egg quality and increased miscarriage rates there. So what they found was that the risk of miscarriage decreased as AMH increased. So the higher your AMH, so the more normal your ovarian reserve, the lower your risk of miscarriage. So women with severe DOR, an AMH of less than 0.4, miscarried over twice the rate of women with an AMH greater than 1, which is considered normal. Next slide. So bottom line, I think the take-home point here is that measuring ovarian reserve may be helpful. I think a bigger question here is what do you do with that information? But as Amber mentioned at the beginning, knowledge is power. And I think, you know, just educating OBGYNs as well as patients that there may be a correlation here. So in addition to the normal workup that you would do, potentially karyotypes and antibody testing, just checking an AMH, you might actually see that there's a correlation there. And, you know, depending on how low that ovarian reserve is and the age of the patient, referral to an REI may be warranted. I think that the controversy lies kind of in what you do with that information. You know, more studies are needed to determine whether patients with RPL and DOR, whether they all warrant IVF, or do you tell them to continue to try on their own and try empiric treatment like you know, potentially would in a younger patient. Would these patients benefit from genetic testing for aneuploidy? Because as we said, perhaps there's a correlation with aneuploidy rates as well. So I think that's coming down the pipeline and more studies are needed to elucidate that. But I think at least having that information would be beneficial for the patient. Next slide. So next, as Dr. Hayes gets ready to kind of talk about this, so I think environmental factors, industrialization, endocrine disruptors, all of those are really big topics right now in the 20th century. So more women we know are delaying childbearing for careers and for other reasons. We also know, you know, that the average age at marriage and first live birth has increased 2 to 5 years since the 1970s. So all of these societal and behavioral shifts are very pertinent in also kind of talking about ovarian aging and what you do with that information. Many women also do not realize that monthly oocyte loss occurs regardless of age and OCP use or overall health. So interesting, if you talk to patients, I'm sure a lot of you have heard patients actually think that if they're on birth control pills continuously, they are stockpiling eggs. But if you look at the physiology and the mechanism behind how ovarian aging works, we know that that's not true. And these follicles undergo atresia, and this depletion happens regardless of whether you're on OCPs or not. So again, just educating women to know that regardless of what you're doing to try and decrease depletion, part of that is just biology, and that it is what it is. Birth rates for women ages 35 to 39 and 40 to 44 have been more than doubling in the US since 1995. And as we just mentioned, a combination of social pressures and potentially damaging environmental exposures may be a cause for concern. So obviously, just in this day and age, even more so than before, a very relevant topic. So I will now turn it over to Dr. Hayes to talk about environmental factors.
Thank you, Julie. So I'm going to touch on environmental effects on ovarian aging. And when I think about environment and the effect on the ovaries, I think in a broader sense, we're thinking of our external environment and things that could be poisoning us from the outside. But along those lines, I'm also going to touch on, the environment in that patient's body. How is that impacting their ovarian aging and how quickly or slowly that will happen? So oxidative stress increases with age, and we know that there are many lifestyle factors that can definitely accelerate that and influence that. Obviously, smoking and alcohol, those are big topics that we talk to all of our patients about, and I'm sure all of you do too. But also things like the increasing rate of obesity as people get older, and unfortunately decreasing exercise as well. Those things can lead to chronic inflammation, which in turn can impact the ovarian aging. Stress, so emotional stress or physical stress also is pro-inflammatory. We're going to touch on some of the environmental factors that have an influence and some interesting information about how diet may play a part in ovarian aging. A lot of it, when you boil it down, comes down to pro-inflammatory state and how that affects all the cells in our body, including our oocytes, and what can be done about that. And are these things the impact of a fragile egg, an older egg, and how these cumulative effects from the environment start to have more and more effects on that as time goes on. So obviously we know that it's been well studied that sperm counts have dropped drastically since industrialization started. There has been production of thousands of chemicals in manufacturing, pharmaceuticals, our personal care products, our household items, all of which we're exposed to on a regular basis, and we don't frankly understand a lot about the long-term effects of these things. We also don't always understand how long these substances are persistent in our environment, and do these accumulate and cause more impact the longer we're exposed. The other problem is research on these topics is very challenging because the bottom line is it takes a long time to get some of this information. They'll often do studies, but shorter studies to see impact of higher effects or higher doses of these chemicals, but the overall impact on ovarian aging can take decades to uncover. Next slide. So there are over 100,000 chemicals registered in the US, and we're adding thousands each year. A lot of these are likely to be, and we know that many of them are endocrine disrupting chemicals. And Amber Cooper is going to touch on this in a little more detail because this is such a hot topic and so interesting. We're just learning more and more. A lot of them are pervasive in the environment. A lot of these toxic chemicals have not really been truly tested for health effects because they're emerging so rapidly. There's not time to test them. And low-level exposures can cause issues over time. The studies to check the safety of some of these chemicals may have been done at higher doses. So we may know what shows an impact right away, but we may not know the impact of lower-level exposure. And like I mentioned before, these studies are tough because they take years and years to complete. So the external environment we know is playing a part, and Dr. Cooper will talk about the EDC chemicals, how that's impacting our ovarian aging. But it's also interesting to think about some of the issues that patients have control over. So lifestyle choices and their nutrition can have a significant impact on ovarian aging. And the way I like to think about overall health and nutrition is that any choice you make that's good for longevity is probably good for fertility and for ovarian health. So we know that diet matters. We know that if we eat a typical Western diet, that it's affecting our brains and our nervous systems and our hearts. And so of course it's affecting sperm and eggs as well. So when you break it down, it can really be several components of the diet that can be at fault. And so it can be the composition of the diet. It can be the ratio of the fats that we eat. So omega-6 to omega-3, if in our Western diet, our ratio is about 15 to 1 to 17 to 1. It should be more like 1 to 1. And those omega-6 polyunsaturated fatty acids are more pro-inflammatory. So over time, that has a huge impact. So caffeine consumption, caffeine in reasonable amounts can actually have an antioxidant effect. And so it's also important to make sure diet contains appropriate antioxidant vitamins, vitamin A, C, and E. The foods that we know have omega-3s, nuts, seeds, lots of fruits and vegetables for those micronutrients. And believe it or not, a lot of herbs and spices are incredibly healthy and function as antioxidants as well. Obesity is pro-inflammatory. Alcohol and tobacco we touched on. Some of the ways that you can lower inflammation in the body would be with regular exercise, which has a major impact, as well as relaxation techniques. We know that regular meditation, regular yoga will also decrease inflammation and in turn may affect overall health and ovarian aging. And then of course there are some supplements that we'll briefly touch on too. So what is the impact of vitamin D on ovarian aging? Well, it appears that if you're vitamin D insufficient or deficient, you have accelerated ovarian aging. And we know that vitamin D is hugely important throughout the body. If you're vitamin D deficient, you have higher risk of all-cause mortality. And we know that there are receptors for vitamin D in the ovary, in the uterus, in the placenta. So some interesting studies looking at vitamin D and impact on eggs and fertility. There was a study showing that as vitamin D levels in follicular fluid increased, so did the clinical pregnancy rate. So that would imply that the effect is somehow on the ovarian follicles and on the eggs themselves. There have also been studies that show in recipients of donor egg, so women who are intended parents receiving donor embryos from donor egg, there's a decreased clinical pregnancy rate in the women who have insufficient vitamin D levels. And because you're taking the factor out of follicle development and egg development, and we're really just focusing on does the embryo implant in the uterus in these patients, we see that it might be very important for implantation in this patient population as well. In fact, the difference was 78% versus 37% in the deficient population. However, there's another study showing that if you control for some of these things, so if you do frozen embryo transfer and you use a euploid, so a PGT tested embryo, you actually don't see a difference in pregnancy rate. So that might be eliminating some of the uterine factor, and it may also be eliminating, the follicle and the egg factor as well by eliminating aneuploidy. But the overall mechanism for vitamin D is still a bit elusive, whether it works on the follicles, implantation, aneuploidy. We know that vitamin D level, it does correlate positively with telomere length, which is a sign of longevity and lifespan of the cell. So that's very interesting. And that the telomeres can actually lengthen when vitamin D levels are supplemented appropriately. So the bottom line is that oxidative stress, damage to the eggs, ages the eggs. So oxidative stress and telomere shortening are seen with aging. Therefore, mitochondria, spindle formation, DNA repair genes, all of those things don't work as well. And what that translates into is aneuploidy and arrest of developing embryos. So a lot of studies have looked into the benefit of supplementing with some pretty powerful antioxidants, such as coenzyme Q10, melatonin, NAC, other antioxidants that have been helpful to improve egg quality and then embryo quality in our fertility population. And at Vios, we actually have put together some high quality supplements that contain very powerful antioxidants that we frequently use for our patients undergoing treatment, whether or not they actually have diminished ovarian reserve and signs of accelerated ovarian aging. It may be beneficial for a lot of patients. The optimal timing as to when to start is probably before they even see us. So 3 to 6 months of supplementation will give the most benefit for these patients. And if you have patients that are interested even before seeing us, they're able to obtain these vitamins on our Vios website. So if they have any questions, we can walk them through the benefits of the different types of supplements.
All right, thank you. These various, I mean, my mind is, first of all, I need more vitamin D, and I've gained the COVID-19 pounds, so I gotta get rid of that too. No, just kidding. But I'm gonna kind of take the last few slides just to touch on kind of an environmental piece that's kind of near and dear to my heart, which is endocrine disrupting chemicals. So, you know, if you haven't heard the term EDC, it's become a more popular term over the last 5 years, definitely over the last 10, but especially over the last 5, even a more heated discussion. And what it really is referring to is either it's single chemical or combination of chemicals in the environment that somehow interfere with hormone action, whether at the level of the receptor or in production of hormones or release of hormones by endocrine organs. There are probably thousands. There are countless studies now that say EDCs affect human health. We think it's probably mediated more by a gene-environment interaction, so it's very, very complicated. And this whole discussion that, you know, with industrialization, that we die less from bacterial infection, but we may be seeing more cancers, autoimmune diseases, chronic diseases, and also infertility and airway issues are related to some of these EDCs. The half-lives are incredibly complicated to study, and the combination and synergism makes it so complicated. So you'll find environmental research is probably one of the most understudied areas at the NIH. Next slide. So, you know, there have been numerous organizations that have made it a priority. So everything from, you know, both in the US and Europe and actually worldwide, the endocrine societies put out some pretty strong statements and really summarized thousands of studies, to be honest with you now. And they really have said, bottom line is there's no longer any doubt that exposure to EDCs are contributing to chronic disease. And infertility is just one thing in this bucket. And the International Fertility Society has put out statements too, as well as the American Society of Reproductive Medicine. Next slide. So if you look at endocrine disrupting chemicals and just female health overall, so we know there's data to show it impacts the ovary, the uterus, the vagina, and it may affect every stage of oocyte formation and development, even from just the endowment. And there's actually studies that potentially in utero exposure, so whatever, you know, mom is consuming or exposed to may impact the oocyte endowment of that female fetus in utero, may impact hypothalamus, pituitary, and the whole HPO axis, the timing of puberty, infertility, like we're talking about, abnormal cycles, endometriosis, and other autoimmune or inflammatory diseases, adverse pregnancy outcomes. There's a really nice study looking at, it's called the NIH Life Study, if you ever look it up, where they recruited all these couples and they were looking at exposures to EDCs as they were attempting to conceive. And they found that both men and women, so they were looking at sperm quality as well as women and their cycles and getting pregnant, staying pregnant, as well as their egg pool. And they found that endocrine disrupting chemicals were associated with a delay to conceive. Next slide. So we did a study that was published in 2015 in PLOS1, and it was a study where we did a secondary analysis of the NHANES database. And if you're not familiar, I'm sure you've heard the term. It's, you know, one of the largest sort of representative samples of the US non-institutionalized public, really. And it really represents all socioeconomic statuses, urban and rural, and it's a really, really well done sampling. It's questionnaire, they take blood and urine, they do them every sort of 5 years. And you know, what it's done then is it's a really incredibly complicated weighted database. And what we looked at was exposures to EDCs as measured in the blood and the urine as it related to age at menopause. And what's interesting is you could take a sampling of women who had exposures to all these EDCs. You could take about 1,500 women, and the way they sampled the United States, it represented about 8 million menopausal women across the US. Next study, next slide. I keep saying that. So these are sort of things we looked at. And if you can see in this picture, it might be a little bit hard to see, but dioxins, phthalates. Phthalates are what make plastics sort of malleable. Here, as I sit here being really bad and drinking this bottled water, which you really should drink out of, you know, stainless steel, glass, or paper, but I'm being bad today because I was in a hurry. But phthalates are what make these bottles sort of malleable. And they're also what make, you know, our conditioners and our shampoo and our facial lotions have the textures that they do. And so they're very, very hot topic in female health and exposure right now. Flame retardants, phenols, PCBs, pesticides, polyaromatic hydrocarbons, and phytoestrogens are things that we studied. Next slide. And I could go into a long sort of discussion, but I just want to summarize the study. I mean, we did a very complicated analysis and a primary and secondary analysis. We looked at sort of dose-dependent responses and threshold analysis in the highest exposure group. We really focused on the EDCs that have longer half-lives as well as phthalates, because you can get really complicated discussion if we're looking at age at menopause and what their exposure was over time and where they lived, who knew, because you couldn't track where they lived when they were younger. But what's very interesting is women who had the highest levels had earlier menopause on average 2 to 4 years, but we had some that had very, very early menopause. And, you know, to put that in perspective, if you were exposed to continuous tobacco smoke, which we know is related to earlier menopause, on average, it's about a year, year and a half. And so it's pretty profound, some of these exposures. And put another way, the other analysis, we had the odds of being menopausal were up to 6-fold higher for each 1 unit increase log of EDC exposure. And so it was a pretty profound association that we found with all of them across the board. Next slide. So you could say why? What is the biologic plausibility? It's potentially slow damage over time. You know, our eggs age with us, and even though if you go back to that outer cortex, there's not a lot of vascularity there, it may be pervasive in the environment, it may be exposure as the follicles are recruited, or it may be some sort of systemic inflammation and other pieces to that. The LIFE study looked at some of these things and some of the same PCBs that we found that even if they were banned in the 70s, they still exist in the water, in the soil, and some of the foods we eat now. They just don't even decay over time. And that's what's a little scary about some of these things. And the same ones, like I said there in LIFE, we saw. In a utero exposure, there's some emerging studies that, you know, adolescents in these certain industrial areas that were exposed to even more PCBs had earlier menarche and thelarche, and intrauterine exposure to diesel also showed associations with more diminished ovarian reserve over time and increased risk of premature menopause. So what if patients ask you, next slide, what they can do? How do I decrease some of these environmental exposures? Obviously, stop smoking, filtered water. You know, at the end of the day, if your water is pretty safe, tap water may be better than bottled water, especially if it's in plastics because of these exposures to phthalates, but still filtering it may be a better way to go. reduce fish with mercury, dioxins, and PCBs. There's a lot of EPA kind of statements out about these things. Using organic, you know, you can go into a whole debate about organic, but you know, it matters for some things probably. You know, could it be a term that's overused for other things and not well regulated? There's a lot of controversy there, but you know, it probably does matter for certain things. Wash and peel anything you have, even if, you know, wash it even if it does have a peel that you're going to peel off. Try and reduce pesticide exposure as much as you can. Be aware of plastics. Personal products, it's really hard. As I always tell patients, you know, stand in the shower and read the back of your shampoo bottle. You know, it's hard to even know what those ingredients mean. So I think women are desperately trying to find anything from makeups and deodorants and things, personal care products that are potentially safer. And there's a lot of mixed information out there. Use greener products in general when you're cleaning your home, and avoiding synthetic air fresheners. So a lot of these candles and air fresheners, there's a sort of a lot of data against right now in some of these fragrances. So kind of in conclusion, why is ovarian aging so important? You know, knowledge is power, empowering, you know, your patients to understand their ovarian aging, to increase awareness both of just natural ovarian aging, but really pathologic ovarian aging, really offering and, you know, early access to some of these things like AMH and antral follicle count. And while AMH may not predict, can you get pregnant tomorrow, it definitely has the ability to predict some other things. And especially if you follow it over time, you know, be aware of the environment, oxidative stress and DNA damage, early diagnosis, access to preservation options, and egg freezing is much more successful today than it was 15, 20 years ago. And to collaborate with researchers and improve treatments. And that's why, next slide, we have our excellence program where we really do try to get patients in very quickly, not only in patients who have a cancer diagnosis, autoimmune diagnosis, and facing toxic therapies, but also patients who suddenly find out, like I had one today, a 30-year-old whose AMH was suddenly 0.1, and she just checked after her sister failed her IVF stimulation, you know, and how do we get these patients in and counsel them and consider fertility preservation? And that's really what we try to do at Vios. We really try to make unique financial packages for patients who may not have coverage. We even help them sort of with hormones in that progression of ovarian aging. We work with a lot of alternative and complementary therapies, nutritionists, acupuncturists, exercise programs, mental health, genetic counselors. They have access to third party if they do go on to need a donor egg, and access to early research studies. So we threw a lot of information at you today, and we touched a lot of areas of ovarian aging, both normal and abnormal. And we know we've already had some early questions sent in, and we are open to Q&A. Erin?
Absolutely. Thank you. Thank you, everyone. That was excellent. Thank you, speakers. So I do invite everybody who is on the webinar this evening to go ahead and put your questions into the question and answer box that will appear at the bottom of your screen there on Zoom. If you like, you can also send it through the chat. We'll get it either way. And so feel free to go ahead and pop that in now. We did have a couple of questions submitted early that I wanted to start with. And one was a two-part question. I think you've sort of addressed the first part, but I'll let you expand if anyone has more to share on that. But the question of diminished ovarian reserve or premature ovarian failure for women in their 20s, why? I think that's largely been addressed, but the second part is, you know, how common is this? So I'd open that up for all of our speakers for a discussion on the common aspects of these conditions.
I'm happy to make a comment. You know, I think it's a good reminder that the normal age of menopause is about 51 and a half. So normal would be 45 to 55, early menopause 40 to 45, and primary ovarian insufficiency, kind of what we used to call premature ovarian failure. We say primary because it's at the level of the ovary. Ovarian insufficiency, because it can wax and wane, is before age 40, which can be anywhere. It's quoted at 1 to 1.8% of women why 90% of the time we don't know. There's some ongoing pretty neat national studies. We are involved in one of them, Vios is the Personalized Reproductive Medicine Network, where they are doing whole genome sequencing to try to figure out why. The things we know about are, this kind of surgical exposures, the toxic therapies, increased risk in women who are pre-mutation carriers for Fragile X, mental retardation, FMR1 gene. There are some other potential genes that have been identified that are heritable, but most 90% is idiopathic, and really we don't understand why, and that's really hard. I usually got to tell women they didn't do anything wrong over the course of their life. It wasn't their beer drinking in college or their 20 years of birth control pills and all of those things. So I wish we knew more.
Thank you. Anyone else care to comment on that one?
I have a quick comment, Erin.
Wonderful.
So I was
Thank
going
you.
to add that, I think although we have definitions for POI, early menopause, there's also this gray zone where we catch some of these patients, like Amber was saying, that patient that came in with an AMH of 0.1, their AMH shows what their oocyte pool might be at that moment. Then you check an FSH on day 3 and it's through the roof and it's almost at that menopausal level. So there's a subset of patients, so not all patients with diminished ovarian reserve are created equally, and it's a bit of a spectrum there. And there are some patients that are kind of, in that gray zone of impending POI as well. So I think you bring up a good point, or whoever asked that question, it's more common than you would expect in these younger patients. And sometimes we do kind of catch them at that moment where, because they do have age on their side at a younger age, we might be able to kind of, grab that one healthy egg while they still have it before they actually reach menopause.
Thank you. So the next question we had submitted is, I think there's a lot of emphasis put on preserving fertility and in particular freezing eggs. But this question is, at what age do women plan to use those frozen eggs?
Take this. I think this is a great question. So patients often ask, well, if I'm freezing my eggs, what does that mean? And what age should I use them by? There's really no timeline where we say you have to use them by within 5 years or within 10 years. We usually treat patients for implantation up till age 55, as long as you're healthy. So I think it's important to remember the uterus is more of a muscle, and it doesn't age, and we don't deplete anything like we do with our ovaries, where they're fragile and it's a follicular pool. So long as you're overall healthy, meaning blood pressure, diabetes, BMI, and all those other factors that do go into play when you're looking to get pregnant, I think that timeline does not exist. I think the rate limiting, or the one that's really fragile and sensitive, is the ovarian pool and the egg reserve.
Thank you.
I'd like to add to that. So that's absolutely right, Roohi. I think that what we find is that when women freeze eggs prior to their 30s, they're much less likely to use them than women who freeze a little bit later. But then there's the trade-off of ovarian reserve and egg quality. And so I think there's not necessarily a right or wrong time to freeze and a right or wrong time to use those eggs. They can come back and use them whenever they are ready, or maybe they won't need to. But I think kind of along the lines of what Dr. Rhee said, we don't know unless we check AMH on some of these women where they stand. And so all of us have seen women in their 20s with abysmal ovarian reserve who we don't know when that started to decline more rapidly because it's very individual, but it's nice to catch them as early as possible. So I would say don't discredit anyone's questions about fertility preservation. If your patients inquire about that, it's just a great idea to get a little basic evaluation, like just an AMH level. Very simple. And if you aren't sure how to interpret it for your patient, we are happy to help with that.
Thank you. So we've had a question come in here in the question box. Will egg supplements help with low ovarian reserve and prognosis of pregnancy?
It's a multifactorial question, and I think everybody on here would agree. So when you look at the studies, those vitamins have been shown to feed and help nourish the surrounding cells of the eggs, the granulosa cells, the cumulus cells, which will then secrete more hormone that some studies have shown, like supplementation in vitamin D and CoQ10 has been shown to increase your AMH. And I always tell my patients, or we tell our patients, that we don't grow more eggs, but you've nourished the ones that you have, so it could qualitatively improve your outcome. So all of those supplements, especially the ones we have at Vios, have been well studied in an animal model to show an improvement in either oocyte function or oocyte quality, as defined by function, the ability to fertilize and develop into a blastocyst.
Thank you. Anyone else care to comment on that particular question?
I'll add that, you know, it's tough. We have, even you take couples with, I'm going to say, you know, advanced age, maybe a lower egg pool, and then it gets even more complicated, which is why we really try to focus on personalized care, like I discussed in the beginning, because, you know, not every patient is the same. And there are patients that may benefit from additional even adjuncts. And some of these get controversial because when they're studied in big studies, they may make no difference. But in smaller sort of cohorts of women that really, when you hone in on certain causes, you know, how do our follicles make estradiol? By converting androgens to estradiol. So, you know, there may be androgen supplementation that may improve the follicular environment. You know, as Roohi just said, CoQ10 is thought to maybe help the mitochondria and the energetics of the egg, which, you know, the egg sort of cytoplasm is really responsible for lining up the chromosomes and help them divide, which in turn can lead to aneuploidy. And you know, it's very, very complicated in this process on where we really try to pinpoint how can we help and how can we personalize treatment for this patient. So I think the bottom line is, you know, going back to sort of, you know, that clean environment as we can, lowering inflammation and supplementing things that potentially can improve that intrafollicular environment may improve the egg and the uterine environment.
Thank you, everyone. Excellent questions, excellent information. Really appreciate everyone joining us this evening. And if you're watching this replay, we appreciate you watching the replay. And big thanks to Dr. Cooper and Dr. Rhee in our St. Louis region, Dr. Jeelani in our Chicago region, and Dr. Hayes in our Milwaukee region. We all appreciate your time and expertise as well this evening. So if anyone does have follow-up questions for any of our providers, or if you are interested in coordinating on some type of patient care, please reach out to us. The easiest way is viosfertility.com. We'll be sure to get you connected to the right person very quickly. And we look forward to connecting with you again here in one of these webinars or in another one of our provider interactions that we'll have here over the next few months. So everyone have a lovely evening. Thank you so much. And we'll talk soon. Good night, everyone. Bye-bye.
Good night. Thank you.
Good night.
Thank you.
Thank you.